at the University of Southampton in the UK. He has a background in influenza research and is recently doing work for the NIHR about the utility of point-of-care tests for infection. This morning, he will present the results of the interim results of a study that is currently doing at the moment, which is a syndromic molecular point-of-care testing for gastrointestinal pathogens in adults presenting to hospital with suspected gastroenteritis. Before we start, we just want to highlight that there's a Q&A box on the right side of your screen, where you can capture all the questions that you have, and Dr. Clark will be answering to the questions at the end of his presentation. Thank you, Dr. Clark, for being here with us. I will give you the floor so that you can start presenting your presentation, please.
Okay, thank you very much for that introduction, Natalie. Welcome, everyone. Can I just check, Natalie, can you hear me okay?
We can hear you very well, Dr. Clark.
That's brilliant. Okay, well, thank you very much for inviting me here to share my research with you all today. So I'm going to talk to you about the interim results of my randomized controlled trial, Gastropoc, which compares point-of-care testing using the Filmora GI panel with routine clinical care in adults presenting to hospital with suspected gastroenteritis. But before I go through some of the results, I just need to put up my conflict of interest slide, and I'll just give you a minute to look at that. And I guess I'd particularly point out that although BIOFIRE have provided the equipment and consumables for this study free of charge, this is an independent, ethically approved research study, and BIOFIRE have had no input into the design or conduct of the study. I also just need to start with a quick explanation of some of the terms that I'm going to be using during the talk. So throughout the talk, I'm going to be using the term point-of-care testing, and as this is really the purpose of the study, but I'm aware that although we're using the Filmora test as a point-of-care test in the study, it isn't clear-waived in the US for this purpose. And so just to be clear right at the beginning, the data I'm presenting comes from an ethically approved research study where patients gave written informed consent to take part. It is not an evaluation of routine clinical care at my institution. I've also been made aware that the use of rectal swabs is not currently FDA approved for use with the Filmora. And again, I just point out that we are not advocating for the use of rectal swabs in routine clinical care. We are using them in the context of an ethically approved research study. Okay, so now I've got that out of the way, let's talk about gastroenteritis. So, as I'm sure most of you know, gastroenteritis is caused by a very large diversity of pathogens, and this is some data from a study in adults and children from the UK a few years ago. And this just nicely exemplifies the fact that if you test people with gastroenteritis, there's a very large number of different pathogens that you can identify. And so if you're looking for pathogens, you need to have a very comprehensive syndromic approach. It's also worth noting that even when you look very hard for pathogens, in this study, 50% of patients had no pathogen detected. Okay, so I work in the UK, and this is the current pathway for suspected gastroenteritis in patients presenting to hospital in the UK. And so what happens is anybody who comes in with diarrhea and vomiting or a history of diarrhea and vomiting is isolated into a side room, which is single accommodation rooms. And this is really a consequence of the big problems that we had with C. diff about 10 or 15 years ago. So all patients go into a single room accommodation, and then they have a stool sample sent, or at least they're supposed to. It doesn't always make it to the lab, but where it does, it then undergoes a whole raft of different tests, including culture, immunoassay, PCR, and microscopy for the different pathogens that could be causing gastroenteritis. And this process takes at least 2 or 3 days to generate a full set of results. And so if the test is negative, patients then leave single-room accommodation. They're de-isolated. And if they had antibiotics started presumptively, those antibiotics will be stopped and alternative diagnoses will be investigated. If the test is positive, then they'll remain in side-room isolation, and if the test is positive for certain pathogens, certain bacteria, they will have directed antibiotics for that, C. diff, for example. And maybe they'll have their antibiotics changed if they were on the wrong agent. Okay. But there's obviously a lot of problems with doing things this way. So the biggest problem is that a lot of patients who come in with diarrhea and or vomiting actually don't have infectious gastroenteritis, and so they're isolated unnecessarily for several days. The other problem is that patients are started on antibiotics presumptively, often for C. diff or for bacterial gastroenteritis, and a lot of the time they don't have those things, and they're on the wrong antibiotics for several days before you know exactly what they've got. And alongside that, there's a delay in effective treatment as well. It's not uncommon for patients who turn out to have gastroenteritis to have unnecessary investigations. Patients with Campylobacter, for example, where they have an inflammatory response and often a bit of bloody diarrhea, it's not uncommon for those patients to go for endoscopy. And if you knew that they had Campylobacter right from the beginning, obviously you wouldn't do that. And then there's patients with inflammatory bowel disease where there's a lot of uncertainty as to whether they have a flare of IBD or whether they've got an infection, and it's not uncommon for patients with an infection to inappropriately get steroids and other immune suppression because of the delay in those diagnostics. And so if you wanted to redesign the pathway for gastroenteritis, it would look something like this. So a patient lands in hospital with suspected gastroenteritis. They have a point-of-care test with a comprehensive syndromic molecular panel. If the test is negative, they don't get isolated in a side room, in single-room accommodation, and they don't have antibiotics, and alternative diagnoses are pursued from the get-go. If it's positive, then they go straight into a side room to protect other patients from their infection, and they have directed antibiotics for bacterial gastroenteritis where appropriate, including C. diff. And so I'm sure you have all seen this. So this is the Filmora gastrointestinal panel, and this is a fairly comprehensive syndromic molecular panel for GI pathogens and includes bacteria, parasites, and viruses. And so in the UK, we have something called NICE, the National Institute of Clinical Excellence, which gives us guidance on what we can and can't use. And more diagnostic devices are going through this appraisal process. And there was an appraisal in 2017 where they looked at syndromic molecular panels for gastroenteritis, including the Filmora, and their conclusion was that they couldn't be recommended because of the lack of any studies looking at health outcomes or resource use. And so they called for research studies to be done, and they even went so far as to suggest some outcomes, including length of time in isolation, length of stay in hospital, and change of a treatment plan as a result of testing. And so we went on and designed and performed the Gastropoc Trial. So this is a single-centre, pragmatic, randomised control trial where adults presenting to hospital with diarrhoea and vomiting of less than 14 days are recruited and randomised one-to-one to either receive point-of-care testing using the Filmora or to routine clinical care, where they have their stool sent to the lab for standard tests. So if they're randomised to point-of-care testing, they have a stool or a rectal swab where they can't provide a stool, which happens more commonly than you might think in patients coming into hospital with gastroenteritis, and that is immediately tested on the Filmora machine with the GI panel, which is housed in the acute areas, and the results are then delivered to the clinical team along with infection specialist advice, and the results are also given to the infection control teams as well. So the sample size there is 150 patients per group, and this is really powered based on some assumptions about the effect the point-of-care tests might have on the primary outcome, which is the time in isolation, the time in single-room accommodation. And this is a particularly important outcome for us in the UK, as we've got a very limited number of side rooms, and I think this is probably similar for a lot of European hospitals. So the study is supported by BIOFIRE and funded by the University of Southampton. As I said, the primary outcome is a duration of time in a side room, and the secondary outcomes include all these different things here, including the turnaround time for the results, the proportion of patients with a diagnosis, and the use of antibiotics and length of stay. And there's some safety outcomes in there as well. And so we performed an interim analysis after about a year, and at that stage we'd enrolled about 50% of the patients. So there's 140 patients enrolled, 70 in each group. And there was one patient withdrawn in the point-of-care group, as they didn't actually get point-of-care tested, as a patient declined. And so you've got 69 in the modified intention to treat analysis in the point-of-care group and 70 in the routine clinical care group. The baseline characteristics are there, and you can see that they're well matched between the groups. About 30 or 40% of patients have known inflammatory bowel disease. And so if we get on to the results, so the first slide shows the median turnaround time for results in both groups. And so for point-of-care testing, we managed to get a median turnaround time. So this is the time from enrolling the patient to giving the results to the clinical team of 1.7 hours. And this compares to 61 hours for routine clinical care. This is obviously highly significant. In addition to that, we found that a much higher proportion of patients were positive when tested with point-of-care testing, because we're using the Filmora, which is very comprehensive and tests for a large number of pathogens and is also molecular, versus the control group, where only 21% of patients had a pathogen detected, which again is due to a mixture of things, including the use of culture-based diagnoses for bacteria, and also for the fact that not everybody gets tested for everything as part of routine clinical care. So we identified a much higher proportion of patients. And this just shows you the breakdown of the pathogens that were detected in the point-of-care group. We get quite a lot of Campylobacter here in the UK, particularly in the summer. The next biggest group is a variety of different E. coli's, and then C. diff here in green. And you can see that even though we're detecting a wide variety of pathogens, the largest group, in fact, is patients who didn't have a pathogen detected. In other words, didn't have infective gastroenteritis. So if you look at the pathogens detected in the control group, so a much smaller proportion of patients, but still Campylobacter is the dominant pathogen that is detected. And so what we did is we had stored samples from patients that were in the routine clinical care group, and retrospectively we went back and tested those using the Filmora to have a look at which pathogens were missed with routine clinical care. And you can see that there's a relatively large number of pathogens that weren't detected with routine clinical care, including some things that are pretty important. So 4 cases of Campylobacter there, 5 patients with norovirus, 2 patients with Shigella. So that's interesting. The largest group here, of course, is the E. coli's, and that's mainly because other than the E. coli 0157s, these are not tested for with routine clinical care. Okay. So we detect more pathogens and we do it very quickly, but what difference does it make to outcomes? So if you look at side room use here, pretty much everybody is isolated and put into side room accommodation as soon as they arrive, and that is what you'd expect, as that's the pathway. And that's no different between the groups. However, what you do see is that more patients in the point-of-care group are de-isolated, and therefore this translates into a reduced total time in isolation of about 1 day, and this is highly statistically significant. But of course, what you're looking at in that group is a mixture of patients. So you're looking at patients who are positive, who need to stay in isolation, and you're looking at patients who are negative, who should be de-isolated. So if we do subgroup analysis, just looking at those patients who are negative and should be de-isolated, you can see that in the point-of-care group, of the patients who were pathogen negative, the majority of them are de-isolated, compared to the control group, where a much smaller proportion of patients are de-isolated. And I haven't shown it here, but the time to de-isolation is much quicker in the point-of-care group compared to the control group. And this translates into a much larger reduction in the duration of unnecessary side room use, so a reduction in 2 days between the groups, which again is highly significant. Okay, so changes in antibiotic use following point-of-care test result. So another of the outcomes suggested by NICE was to look at this, and this is just a series of examples of the sort of changes of antibiotics that happen with point-of-care testing. So overall, you can see that 40% of patients had a change in their antibiotic management plan following the results of the point-of-care test. And these are just some of the examples here. So, somebody with a negative point-of-care test will have IV cefuroxime and metronidazole stopped. Somebody who's norovirus positive will have their oral metronidazole stopped. Metronidazole presumably had been started for suspected C. diff. Somebody with Campylobacter was on IV cefuroxime and metronidazole, and this was stopped, and azithromycin started instead. And, the theme from this is basically that people cannot tell what patients have got when they come in with gastroenteritis, and they get it wrong most of the time. So patients with C. diff are often on completely inappropriate drugs, and conversely, patients who don't have C. diff are often on sort of empiric C. diff antibiotics. And so having that rapid, accurate diagnosis really allows patients to direct their antibiotic management right from the get-go. And then there's some sort of weird things that aren't suspected. So a patient there was Giardia, where they were on IV cefuroxime and metronidazole, and had that stopped and oral metronidazole substituted. Okay. Looking at antibiotic use overall, what you can see is that the number of patients that get the wrong antibiotics is actually the same between the groups, but what is different is how long they stay on those antibiotics. And so the duration of inappropriate antibiotics is much, much shorter in patients in the point-of-care group compared to the control group by about 2.5 days. And overall, the proportion of patients with an appropriate antibiotic management plan is much higher in the point-of-care group compared to the control group. So moving on to the last set of results, so length of stay, you can see that overall there's a sort of trend. I don't want to overstate this because it's not statistically significant, but it looks like there's a trend for a reduction in length of stay in patients tested with the point-of-care test compared to the control group, and the same if you look at the pathogen-positive subgroup. But this is not statistically significant. Who knows? Maybe it will be by the time we've recruited all the patients, but we'll have to see. Okay, so in conclusion, point-of-care testing for GI pathogens in adults coming in with suspected gastroenteritis results in a faster turnaround time for results and an increase in the proportion of patients with pathogens detected. Despite the increase in pathogens, it's associated with an improvement in the appropriate and timely de-isolation of patients who are negative, and this results in a reduction in the duration of unnecessary side room use. Point-of-care test is also associated with a higher proportion of patients receiving appropriate therapy and a shorter duration of inappropriate antibiotics. So this is my acknowledgement slide, and this is a picture of one of our clinical fellows performing the study in one of the clinical areas there on our medical admissions unit. Okay, so thanks for listening. I think we've got a Q&A session now.
Thank you, Dr. Clark. Thank you, everyone, for attending. If you have some questions, please go ahead and type them down on the Q&A session. If you'd rather talk, let us know, and we'll unmute you so you can ask your questions. So actually, there's one question for you, Dr. Clark, about the data that you presented. So you mentioned that you finished enrolling all the patients. Do you know when you will have the final results of your study available?
Yeah, that's a good question. So we are getting towards the end of the recruitment period now. So I think we've got about another 50 or so patients to recruit. So I think we're hoping to be finished recruitment probably the middle of this year, and depending on how quickly we can collect and process all the data, I think we're looking at a publication at probably the beginning of next year. realistically.
Okay, there is another question as well. Has there been any calculation of differences in cost with and without the BIOFIRE FILMARRAY point of care?
Yeah, so that's a great question, and that's something that we'll be looking into. So we've not done a formal health economic analysis with this study, so we haven't collected quality of life data, for example. But what we've done with our previous point of care studies is do a very simple cost minimization, looking at the cost of the tests and healthcare utilization, and I think we'll end up doing the same thing with this study, and we've collected all that data. Yeah, so we intend to do that.
We do have another question. How do you know that the yields from the swab are equivalent to the stool samples?
Okay, so once again, I probably just need to stress that I know that rectal swabs are not FDA approved for use with the FilmArray, and this is part of a research study. What I would say is that the data so far, and there are quite a few studies comparing the concordance with molecular diagnostics between rectal swabs and stools on both adults and kids, and the data to date so far is that they're pretty much equivalent, actually. So I don't know what's going to happen in the future about FDA approval, but I'm sure it's something that's being looked at. We are testing both stool and rectal swabs. So the way it works is that we will take a stool sample where that is possible, and where it isn't, we'll do a rectal swab and then subsequently get a stool sample when the patient is able to collect it. Because the point of the study is to test as quickly as possible, and people can't always produce a stool at the drop of a hat. And then what we've done is retrospectively look at the concordance between the stool and the rectal swab, and I can say that it's incredibly high, so almost 100%. But again, I don't have that data there, but that will be part of our publication strategy to provide that data to suggest that rectal swabs have utility in this situation.
Thank you. We have another question about asking how you interpret the specimens with multiple pathogens.
Yeah, so this question always comes up, and it's a great question. What I'd say is that for adults, the vast majority of them actually have single pathogens detected, and a lot of the time it's the pathogen that you are suspecting. So, Campylobacter or C. diff, and those are relatively easy to deal with. Occasionally we do have dual or sometimes even triple detections, and it tends to be, the second pathogen tends to be one of the E. coli, particularly enteropathogenic E. coli, EPEC. And what I'd say is that you have to sort of treat everyone on its own merits and sort of look into it. But a lot of the time, EPEC seems to be there as a commensal or as something that's not particularly important. For example, somebody would come in with fevers and blood and diarrhea, which may be bloody, and they'll have a Campylobacter there or a Shigella there and an EPEC. And in that instance, it's pretty obvious. We think that the important pathogen is the Shigella or the Campylobacter. Occasionally in patients with inflammatory bowel disease, where you're not sure whether they've got an infection or not, you'll detect an EPEC, and that's really tricky. And usually these patients are on antibiotics anyway, and so often they'll end up getting a brief course of appropriate antibiotics for that, even though we're not sure whether it's relevant or not. But in the main, most of them are single pathogens, and most of them are pretty easy to manage.
All right. We have an additional question about someone who is surprised that all the patients received antibiotics systematically. So his question is about the criteria of eligibility for patients that are suffering from gastroenteritis.
Yeah, I'm sorry, I didn't hear the beginning of that question very well. Could you possibly repeat it, Natalie?
Yes, excuse me. So there is somebody who is surprised that all the patients received antibiotics systematically. So they are asking about the criteria of eligibility for the patients that have gastroenteritis.
Right, okay. So, yeah, I think if I've got it right, you're saying they're surprised by the number of patients that received antibiotics, and so they're wondering about the eligibility. Well, it's a pragmatic study, and so it attempts to mimic what happens in reality as closely as possible so that the results are applicable to your standard, acute medical unit and emergency department. So the criteria are adult patients who come into hospital with diarrhea and or vomiting. Sorry, Natty, there's a lot of beeping in my ear.
Okay, we cannot hear anything on the outside, so...
Oh, right, okay, well, I'll just ignore it and I'll keep talking. So, yeah, adults, non-immunocompromised adults who come in with diarrhea and or vomiting of less than 14 days duration. And the reason that those, and, a lot of those will have gastroenteritis, but a lot of those patients will have other things. The reason for having very broad criteria, as I said, is to mimic what we do. The problem we have here is that anybody that has diarrhea or a history of diarrhea ends up in side room isolation for many, many days. And what we need to do is prove that they're non-infective so that we can de-isolate them. In terms of antibiotic use, I'm sure that it's the same everywhere, but you'll find that a lot of patients receive unnecessary antibiotics, and the agents that they get are often inappropriate. So you saw their patients, coming in with diarrhea and vomiting, and maybe a bit of inflammatory response ends up on IV Kefir-Met. And it's really about the diagnostic uncertainty that you have with these patients. A lot of patients with gastroenteritis, people are worried about intra-abdominal sepsis because they've got a high CRP and maybe they've, got a bit of tummy pain. And so, yeah, the problem is the diagnostic uncertainty. And once you have the diagnosis that fits with what people have got, it makes things a lot easier. I hope that answers the question.
Yes, it does. Thank you. We have two additional questions. One about the routine practice, asking you if you require culture of positive results for resistance determinations, for example, or do you treat empirically just based on the identification?
Yeah, so that's another great question. So, I guess what you could wrongly infer from the data we presented that you only need to have molecular tests, but of course the problem with that is that you don't get any antimicrobial sensitivity data, and so yes, we still need to do culture where we identify certain bugs like Campylobacter and things like that. So yes, we do, and as I understand it, the molecular mechanisms of the resistance are not well characterized. So I don't think a test that is a molecular test that is able to look at the resistance is on the horizon anytime soon.
All right. We have a question asking if this panel can help to differentiate between the diarrhea coming from the radiotherapy side effects, or if it is a gastrointestinal issue in immune-compromised patients.
Yeah, I'm sorry, I didn't hear the beginning of that question again, Natty. Could you possibly repeat it for me?
Yes, excuse me. So we have a question about asking us if this panel can help to differentiate between the diarrhea coming from the radiotherapy side effects, or if it is a gastrointestinal issue in immune-compromised patients.
Yeah, again, there was a lot of beeping in my ear right at the beginning. I think what you're asking is the test able to tell you in immunocompromised patients whether someone's got gastroenteritis or whether they are getting mucositis from their chemotherapy? Was that the question? Yeah,
that is the question.
Yeah, sorry, again, lots of beeping in my ear. Well, all I can, yes, potentially. I mean, what the test will tell you is whether you've got potentially pathogenic bugs in your stool or not. So it should be able to differentiate between infective and non-infective diarrhea. We've not tested it in immunocompromised patients, but, one could, So, it should be able to tell you the difference between chemotherapy-associated, serositis and mucositis and a genuine gastroenteritis, yeah.
Another question asking you if you think that NIHR might review their recommendation based on the results of your study?
Yeah, again, sorry, lots of beeping at the beginning there, so I didn't hear the beginning of the question.
Just wondering if someone is wondering if the NHS will review their recommendations based on the results of your study?
Yeah, so the NHS is and healthcare wing of the Department of Health. The National Institute of Clinical Excellence, or NICE, is the body that reviews evidence for drugs and for diagnostic tests, and it was NICE that recommended further research. So, yes, the idea is that once we've generated high-quality randomized controlled trial data, that we may go back to NICE and ask them to reappraise the evidence.
All right, thank you. I cannot see any additional questions. Actually, there is one, sorry. So let me read it. So we have questions for someone who is asking, but since molecular tests detect DNA, which may not always be associated with lab pathogens, are you aware of any studies in healthy individuals to ascertain the rate of false positive rates or attempt to define pathogen loads that should be attributable to disease?
Yeah, sorry, again, there was some beeping during the beginning of that question, but I think the question was a highly pertinent one, which is that the detection of nucleic acid in the stool isn't the same as that bug definitively causing disease, and particularly in kids, you do see potentially pathogenic bacteria in healthy controls. So, yeah, I think the question was about that.
Yes, that is right? Yes, you're right.
So, sorry, what was the actual...
The question is can we make an association between a result that we get from a DNA test to a live pathogen? And the rest of the question is asking about studies in healthy individuals to show the rate, either to show a rate of false positive or attempts to define the pathogen load.
Well, yeah, I think so. There's some interest in looking at pathogen load, but as I understand it, I mean, for molecular tests, you know, the correlation between CT value or QC value and for gastrointestinal pathogens, that's even more so. You know, with respiratory viruses, there's a signal that the higher the load you have, the worse your outcomes are. But for GI pathogens, I think it's a real mess actually. So I don't think knowing the quantitative, the CT value is going to be particularly helpful in these tests. And we haven't. I think the other sort of element to that question as to whether we had healthy controls to look at the proportion. And we haven't done that because there are lots of other studies that have done that, and the detection of pathogens in adults in developed countries is relatively small. What I would say is that, we're recruiting patients with diarrheal illness, and so if you have a compatible bug, it's not unreasonable to assume that that bug is causing the disease, with the caveats that we've already mentioned about, the E. coli with disease. But usually it's pretty obvious, somebody that you suspect has C. diff and who's been on antibiotics and who's got bloody diarrhea when they've got C. diff, it all makes sense. And the same with things like Campylobacter or norovirus. You have to interpret these tests with the clinical context. And so, the use of these tests still necessitates integration with your infection specialist service, even more so, I think, than...
Have we lost you, Tristan? Dr. Clark, are you still here?
Yes, I'm still here. Yeah, lots of beeping in my ear.
Okay. Sorry. So we have another question about how often we need to run QC as the system is a closed test.
Yeah, sorry, I'm going to have to ask you to repeat that again.
How often do you run QC as the system is a closed test?
Yeah, so obviously the quality control and quality assurance is hugely important with molecular tests, particularly as we're using them outside of a laboratory environment. So we use the standard SOP that is recommended by BIOFIRE with the QC materials that come with it. So we're very meticulous about our quality assurance, and we, the real issue is about looking for contamination, and so we run negative controls pretty much every day.
All right, thank you. You still have a few options if you want to ask questions to Dr. Clark. I don't see any new questions here, Dr. Clark, so I want to thank you for your presentation. Thank you for the webinar, and we wish every one of you a very good day. And if you have questions about this specific panel, you can reach out to your bioMérieux representative, and they will be able to answer to all the questions. And if you have any additional questions to ask to Dr. Clark, you can still use the Q&A, and we can then send him the question and get back to you with the answer. Thank you very much for your time, and thank you, Dr. Clark. Again, have a great day.
Thanks for having me.
Thank you.